Hello, everyone, and thank you for joining us for a breakout session on managing a dual diagnosis of FTD and ALS. We're going to get started so we can use the full time for this helpful and informative session. My name is Kim Jenny, and I'm AFTD's Manager of Genetic Initiatives. This session will be recorded and available on our website after the conference. Participants will be muted for the duration of the presentation, but you can submit questions in the chat as you think of them. Dr. Sullivan and Julia Castro won't be reading the chats coming through as they're presenting, but AFTD staff are behind the scenes to help and share the questions at the end as time allows. As always, our helpline is available after the conference to discuss individual situations. You will also find many helpful resources on AFTD's website. And with that, welcome. It is my pleasure to introduce Dr. Campbell Sullivan and genetic counselor Julia Castro, who will be presenting on managing a dual diagnosis of FTD and ALS. Dr. Sullivan is an associate professor of neurology and neuropsychologist at the Biggs Institute for Alzheimer's and Neurodegenerative Diseases at University Texas Health Science Center in San Antonio. She serves as clinical co-lead for the South Texas Alzheimer's Disease Research Center and co-director of the Biggs FTD program. Dr. Sullivan is the site principal investigator for all FTD, and she leads the Biggs Care Ecosystem, a comprehensive, evidence-based supportive care intervention designed to deliver remote care from specialists with expertise in dementia care. Dr. Sullivan is committed to helping patients and families over the scope of the disease process. Julia Castro is a genetic counselor at the Biggs Institute for Alzheimer's and Neurodegenerative Diseases at the University of Texas Health Science Center in San Antonio. She earned her master's in genetic counseling from Johns Hopkins University in 2023, and she has counseled patients and families with FTD and other neurodegenerative disorders at Johns Hopkins and the Biggs Institute. She's a member of the National Society of Genetic Counselors and holds a bachelor's degree in genetics and genomics, minors in Spanish and psychology from the University of California, Davis. And with that, it is my pleasure to welcome Dr. Sullivan and Julia Castro, who will take it from here.
Thank you so much for that lovely introduction. Julia and I are here together in the same room. So I think what we're going to do is I will start sharing my screen, and then we're going to do the talk in two sessions. So we are here to talk about managing a dual diagnosis of ALS and FTD, or FTD and ALS. And so, as you just heard, we work together in San Antonio at UT Health there, and we're also both core members of the Biggs Institute, which is our neurodegenerative institute. And we're breaking up the talk, by provider. So part one, I'm going to talk about ALS and FTD, and I think it's important to educate ourselves on this very rare diagnosis because it's just not well understood even among dementia centers or primary care providers. And so it's, as caregivers or as patients, we need to sort of educate ourselves so we can advocate for ourselves. So we'll talk about that. I also think it's important anytime we are talking about ALS-FTD is to talk about caregiving, because this can be one of the most devastating disease processes. And so we have to be protective of ourselves and our loved ones. And so it's important to sort of start that discussion now. Part two, Julia is going to go over the genetics of ALS and the genetics of FTD and give us a very nice detailed introduction to that. And then hopefully we'll have some time to answer some of your questions. So that's sort of our overview. So I like to start any talk with sort of an overview of what dementia is, because there can be a lot of just misunderstanding about, what it is necessary or what is necessary to make that diagnosis. And so the first thing we always need to show is we need objective evidence of change. For me as a neuropsychologist, I'm usually looking for cognitive change. So when I take a patient and we do some testing, I'm going to compare that patient to people that are very similar to that individual. So we're comparing him to a group of patients of the same age, same education, same sort of background. And that way I have an idea of where I think the patient should be performing, and then I can just compare that to where they are performing. So I need some objective evidence of change. So maybe I'm looking to see if the patient is doing poorly in learning and recalling new information compared to their cohort, or they're having a lot of trouble with attention, or they're having a lot of trouble just sort of with multitasking and tasks of executive function. So I'm looking for that cognitive impairment. But that alone is not enough for sort of a dementia diagnosis. I'm also looking for associated changes in independence. And that's sort of a jargony thing to say, but really what I'm looking for is how does it affect or how does it impact your day-to-day function? So if I see evidence of memory impairment on testing, is that bleeding over into your real life? Are you forgetting to take your medications? Are you forgetting to pay your bills? Are you having trouble navigating like familiar locations? So it's the combination of cognitive impairment plus that functional decline. That is sort of the threshold, the diagnostic threshold to make a designation of dementia. And now under that very large umbrella, we have different types of dementia. And so the one that we hear about most often is Alzheimer's disease. And that's simply because it's the most prevalent. So 50 to 75% of individuals with a dementia diagnosis do carry an Alzheimer's diagnosis. And then we have another 20 to 30 that will be diagnosed with like a vascular dementia, and then maybe 10 to 25 who are diagnosed with a Lewy body dementia. Our FTD, our frontotemporal dementias, only account for about 10 to 15% of all dementia syndromes or diagnoses. So it's a much more rare presentation. And I think because it's so rare, there's just not a lot of recognition or not a lot known about it. And then of this very rare FTD diagnosis, only 5 to 20% of those individuals will meet diagnostic criteria for ALS-FTD. So we're talking about something that's already rare, and now we're in sort of the rarest of the rare clinical syndromes, okay? And so it can be a little bit difficult how this diagnosis is made and how it's understood. So I think the easiest way to understand it is to think of it on a spectrum, or so the disease continuum. And so on one end of the disease continuum, we have ALS. And ALS is characterized as a motor neuron disease. It's a progressive disease. It's attacking the motor neurons in the brain and in the spinal cord, and it can lead to things like muscle wasting, loss of movement, trouble swallowing, and that's sort of a pure form of ALS. And then on the opposite end of the spectrum is where we have FTD, and there are a few variants of FTD, but overall it's considered a neurodegenerative disorder. And so this is a progressive disease. It's attacking. We have bad proteins that are building up in the frontal and temporal lobes of the brain. And that is causing changes in personality or behavior. It's causing changes in language. It's causing changes in movement. But in a very small proportion of individuals, we will see both ALS and FTD sort of simultaneously. So about 15% of ALS patients will develop FTD, and it's about 15% of FTD patients will develop ALS. But there's all sorts of variability along this continuum. So if we look at sort of the ALS population over here on the left side of the screen, so those with a pure form of motor neuron disease, anywhere from 10 to 75% of these individuals with ALS will show some degree of cognitive or behavioral change. And so they may not be right there in the middle with like a full FTD diagnosis, but they're exhibiting some degree of behavioral or cognitive change. Similarly, 20 to 30% of our FTD patients will start to develop motor changes or motor disturbance that's not severe enough to warrant an ALS diagnosis, but we're starting to see some evidence of that progression and then that change. So you can have patients and families who fall sort of anywhere along the spectrum. And because of that, it can be really confusing, not only for patients and caregivers, but also just, providers to really understand what ALS-FTD truly is. And so I think one of the things I like to show is that the ALS symptom presentation can vary quite dramatically, and you can have any combination of these symptoms. So, you can see changes in motor. So they might have the weakness, the diminished movement, the trouble swallowing. They might also have some changes in language. So they might have an aphasia. They might have poor comprehension, trouble understanding language. And then they might also have some behavioral changes. So they might get a little bit more disinhibited, might start saying things that are a little bit off color, or might not say anything at all. They might also become a little bit more apathetic or have some repetitive movements. So any constellation of sort of in these three columns can dictate what we see clinically. And so there's a lot of variability for patients and for caregivers and for providers. But what I do want to emphasize is if you look at this little bar graph down below, this is sort of comparing your typical behavioral variant FTD participant or patient with those who have FTD-ALS. And you can see with the dark columns, those are our behavioral variant patients. And those individuals, a higher proportion of those individuals will have a high number of behavioral symptoms. Whereas the other end of the spectrum, we have our FTD-ALS patients, and they have some behavioral changes, but not nearly as many as our behavioral variants. So usually I would say sometimes there's, 4 behavioral symptoms versus 8. So it's a little bit like half. And so what's causing that? If we look at sort of like ALS-FTD symptoms, a lot of time what we're seeing clinically or on testing is executive dysfunction. And that is really housed by the frontal lobes. I like to think of our brain like a business, and the frontal lobes, that's the CEO of our brain. That's the part responsible for planning, for organizing, for prioritizing. And so when you start to have changes in those areas, that's when we're going to start to see our loved ones making, poor decisions. They might get a little bit more disorganized. They might have more trouble multitasking. It's taking them longer to understand and to process new information. Or maybe they're really distracted. And so they start a task and then they get distracted by another task and really never end up finishing anything. We also have a lot of apathy. And so apathy, I like to describe as just sort of lack of motivation. They're just a little bit more passive. So they might not be doing as much, may not be as engaged. They just things that they cared about previously is really not holding their attention for as long. We see changes in appetite. So individuals might start to develop a food fad, so they just want to eat one type of food, or they might start eating more sweets. We can see some disinhibition, some jocularity. They're saying inappropriate things. They're being a little bit more crass, a little bit more cavalier. But without question, the one thing I see most often in our ALS-FTD patients is something that we call a nosognosia. And that is just a fancy way of talking about insight. And so insight, that ability for the patient to really appreciate sort of the gravity of the situation, to really appreciate how much they have changed, to recognize that there has been change and to sort of compare themselves to where they were and what they were doing 5 to 10 years ago. That area of the brain often takes a hit. And that plays out in patients who really don't see the point of treatment. And it's oftentimes families will come to me and they'll say, well, he's in denial. And she just doesn't want to accept that she has ALS, or she doesn't want to accept that it's FTD. And it's not, it can look very much like denial, but it's not sort of this volitional, process. It's really a lack of awareness. And it's because that part of the brain responsible for sort of recognizing and appreciating that awareness has really, it's not working as well as it once did. And so anytime we have patients who come to our ALS center and who all of a sudden are saying, no, I don't need a walker, or I don't need that medication, or I don't need that treatment, that's usually sort of an early indication that they're probably going to get a visit to come see me, and we're going to evaluate if we think ALS-FTD is going to be part of the clinical picture. And we do that because when we have someone who is not making good choices, we have degradation of those frontal lobes, it does not have good insight. And then we're asking them to make really complicated medical decisions about their health and their future. It can be really difficult for families to try and tease apart, what is it that this patient wants? What have they always wanted? How do they want their future care to be versus what is the disease? And their perception of the disease is very different. The patient perception of the disease can be very different than the caregiver perception of the disease. And that really comes to play when we start talking about PEG tubes and nutrition, because that is without question often the biggest concern that caregivers will bring to my attention. The patient is refusing care, is refusing treatment, doesn't want a PEG tube, doesn't really see the need for a PEG tube, continues to eat. However, they're aspirating or they're choking, or, they're trying to eat steak when they can only drink, liquids. It can be very challenging for caregivers to try and navigate that. And so I bring this up because, nutrition is it's the cornerstone, and it's important building block really for everyone, but especially in individuals who have ALS-FTD, because poor nutrition is going to lead to fatigue, confusion. It can really make the disease process much, much harder, not only for the patient, but for the loved ones, because, we're the caregivers, or we're watching our loved ones. And so ultimately, I have no dog in this fight. I want to support the patient, and I want to support the family the best way we know how. And so I do have families where, a PEG tube cannot be tolerated simply because the symptoms are too severe, or we might have psychosis that we can't get under control. And it's just, it's a harder disease course, and it's a harder process for everyone involved, but, we can do it. And so I bring that up because we want to start having these conversations now. And we also want caregivers and patients to recognize that sometimes their judgment and their insight is limited. And so, start building that family trust and start having these difficult conversations early in the disease process. And it can sort of make things later on much easier for everyone involved. But we also have changes in speech and language, which can also complicate things. So I like to define speech as sort of how you're saying the words. It's your tongue movement, it's your lips, it's how the words are coming out. And so as that starts to progress, or we have someone with a bulbar onset ALS, their speech might become more slurred or garbled. They might start saying only the most important aspect of the sentence to communicate what they want. It might be a little bit more belabored. We have some people who, eventually lose speech, whereas other people's speech is very much preserved, but they're losing the language. So their mouth muscles and their tongue muscles, move quite well, but the language, so what they're saying is rather empty. So they're losing sort of the words or the meaning of the words. We call that conceptual knowledge. And so because of that, they're really having trouble understanding. They're having trouble understanding you. They're having trouble understanding the doctors, having trouble maybe understanding, these very complicated disease processes. And so that can be especially challenging because oftentimes when we have a loss of conceptual or semantic knowledge, it's not in its entirety. We have these pockets. And so we have these pockets of preservation where you have a patient who is speaking quite eloquently on something that they know quite a lot about. And then you sort of veer them off into a newer topic or something that they're not as familiar with. And then you start to see that they're really having trouble understanding you. So it can differ quite dramatically depending on what areas of the brain are affected. And then finally, we have the movement symptoms. So we have, again, sort of depending where those motor neurons are being attacked, we can have the muscle weakness and the clumsiness. So if it's starting in the limbs, we'll see it, in the legs. You might have a foot drop. It might start in the hands. Their dexterity gets a little bit more challenging. Or if it's the bulbar onset, it's sort of starting in the areas that are responsible for things like swallowing and moving your mouth. And that's where you're going to have things like trouble swallowing and maybe not being able to eat food as they once were. We also have in our bulbar onset patients, we often see pseudobulbar affect. And so those are patients who are crying when they're not sad, or they're laughing when they don't feel anything's particularly funny. And so that's just sort of this like natural reaction that is happening because of the degradation in the brain. And so there are medications that can help with that pseudobulbar affect. And that can bring a lot of relief and comfort, not only to the patients, but to caregivers as well. So that gives us sort of a nice overview of ALS FTD. But I want to spend a little time talking about caregiving, because I think this is a really important component for these families. And so we know caregiving is hard, right? And we have decades of research to show that changes in cognition place a heavy burden on caregivers. But what I think is even harder is that we know patients or caregivers who are caring for loved ones with ALS-FTD have the added burden of not only dealing with these cognitive and behavioral changes, but you're also simultaneously battling this rapidly progressive physical declines. And that, I think, is just sometimes very overwhelming, because you not only are having to sometimes manage medications or maybe take over the finances, but you're also learning how to manage the medical equipment that just sort of goes along with ALS, which can be something simple like a wheelchair or a ramp, but then it can get much more complicated. We can start looking at Hoyer lifts and Trilogy machines and neck braces. And then we have special cutlery, and then we have peg tubes and hospital beds. I mean, the list is very long, and it's a steep learning curve. So you're trying to manage that, but you're also having to assist with decision-making and trying to sort of determine, like, is this what my loved one always wanted? Like maybe they didn't want a peg tube, or is this sort of the disease process? And so it can be very difficult to navigate. We're supervising meds, we're maintaining treatment adherence. And because of all of this, we have found that patients or caregivers for patients with ALS-FTD are 3 times as likely to report high levels of caregiver burden. And so there was one study I like to look at that's studied 55 families with ALS. And so 18 of those were diagnosed with ALS-FTD, and then 41 with just ALS only. And they divided everyone into high and low caregiver distress. And so the single most influential factor to predict high levels of caregiver distress was a diagnosis of ALS-FTD, which we know it's hard, it's causing a lot of distress. But what they found, what was interesting, is that there were some families caring for loved ones who had ALS-FTD, but they had low levels of caregiver burden. So, I mean, those are the people we want to study. And so what they looked at is coping styles. What was different about these individuals? And there's a lot of different theories about coping, but this is one that I like. And it's sort of, there's a few ways of looking and coping and responding to stressful situations. And so, one is task-oriented. And so when you're task-oriented, we're focusing on strategies that are aimed at sort of directly managing the stressor. This is active coping. So we're planning for things, we're creating support. We're focused on trying to manage what's been dealt us. Then there's, emotion oriented. And so these are strategies aimed to regulate emotional reactions to stressors. So, sometimes we use humor, sometimes we use positivity, sometimes we use religion. These are strategies that will help us manage our emotions. But then there's also avoidance oriented. And so these are strategies undertaken to avoid the source of distress. And we've all been there. So we might have some self-distraction. We might use some substances. Venting is one. We might just disengage. We might need a little bit of escapism. And so what they found is that those individuals who had low levels of distress were primarily task-oriented. Those individuals who tried to really avoid the stressors, those individuals had worse outcomes and higher levels of anxiety, okay? And it's not to say that we're always going to be task-oriented. We're, as caregivers, going to sort of vacillate between these three. Sometimes we need to protect our emotions. Sometimes we do need to disengage. Sometimes we just need to stare at a wall, and that's okay. But we need to sort of come back to the task and try and develop these strategies to manage the stressors. And so in an effort to be proactive and to be task-oriented, this is what I always start with any families who are caring for someone with ALS-FTD. Number one is finding a specialized medical center. And so they're listed on the ALS Association website. They're listed on the AFTD website. And so finding your team, finding your people, managing the disease process, I think that can be instrumental. Number two, educating yourselves. So as patients, educating ourselves, as caregivers, educating ourselves, looking at the ALSA and AFTD websites. There's a ton of information out there. There are a ton of YouTube videos. Teepa Snow is one that I especially love for caregivers. But also recognizing that when you've hit a wall, it's okay. And you take a break. We don't need to continually educate ourselves all the time. Sometimes it's too much, and that's okay. And we can go, watch a movie or spend time with friends, or just, spend time with our loved one. Creating contingency plans. So the AFTD has a 24-hour helpline, which is very, very important, especially when we're dealing with something as sort of diverse and rare and difficult to manage as ALS-FTD. The Alzheimer's Association is another 24-hour helpline. Depending on your medical center, they might also offer 24-hour helplines, but having your emergency procedures intact, I think, is very important. And then finally, your emotional support, building that network to help support you. So whether it's the patient or the caregiver, building your team, finding your people. Sometimes that looks like finding someone for individual therapy. Sometimes it's spending time with friends and family. Sometimes it's going to support groups, whether they're online or in person. But finding your people and being okay with, not spending time with them as well. So sometimes support groups can be helpful and sometimes they can be triggering. And so if that's the case for you, it's okay. I want to challenge you to find your group and your support people that are going to be helpful for you as an individual and as a family. Okay. And so that has finished part one. We're going to go on to part two with the amazing Julia Castro, and she's going to talk about the genetics of ALS and FTD.
Perfect. Okay. And thanks to Dr. Sullivan for that really helpful overview. So yeah, to wrap us up, I want to touch a little bit on the genetics piece of this. And I know for so many of you, the question, well, what about my family members? What about my children? What about my siblings? Can feel really important, which is kind of why I want to loop this in as well. So you can see all these little bubbles, and these are all of the genes, or at least a lot of them, that are known to be able to cause both FTD and ALS. Some are bigger than others because some are more common, or at least more commonly known. For those of you who are familiar with this world, C9orf72 is going to be the most common genetic cause of familial ALS and familial FTD, which is why it's in the middle. But you can also kind of see with the color gradation here that just like Dr. Sullivan mentioned, ALS and FTD can be a spectrum. The same kind of goes with these genetic causes. Some of these genes are going to be much more likely to cause ALS. Some are going to be much more likely to cause FTD. And some might be closer to equally likely, okay? And I've included some question marks here as well, because the reality is we're always learning more. We're always discovering new genes. In fact, many of you have been a very key part of discovering some of these genes that are listed here as well. And so I just always want to note that whenever we're talking about genetics or doing genetic testing, it's never quite the full picture. We're always learning more. That being said, with what we know now, estimates would say that about 60 to 70% of those with ALS-FTD who also have a family history of one or both of those conditions might expect to find something on genetic testing that explains why they have it and why there's a family history. And for those without a family history, it's going to be a little lower, maybe closer to 10%. And again, I'll say these numbers are changing and growing as we learn more about how different genes are associated with these conditions. So let's say you're doing genetic testing. Okay, so what can we learn from that? And I will say genetic testing is at least recommended to be considered for anyone with ALS and anyone with FTD, and certainly someone with ALS-FTD. So this is a pretty relevant thing. There are 3 possible results that we could get back from genetic testing whenever we do it. So the first one would be a positive result. So let's say you or your loved one with ALS-FTD do testing and the result comes back positive. Well, what I would say is, okay, that explains why this happened. There's some sort of difference in one of your genes that looks a little different from what we normally see, that explains why you've developed ALS-FTD. And when we get a positive result back, the questions that come to mind for me are, well, are there other medical concerns that we should keep in mind? There are some genes like the VCP gene that are known to bring a couple other medical risks with it as well. Are there any research opportunities? There's a lot of clinical trials going on. There are gene therapies that are happening. There are research opportunities that are specific to individuals with genetic forms of ALS or FTD. And so if you have a positive result, might that open the door to participate in some of those things? And of course, what does this mean for family members? Who should we be talking to? Who might be at risk? And what should we be telling them? It's also possible that we do genetic testing and we get a negative result. And my interpretation of a negative result is, well, right now we don't necessarily have a genetic explanation for why you developed ALS-FTD. And you'll see the first question listed on there is, well, should we consider testing again in the future? And again, I just want to emphasize we're always learning more. It's possible that 2 years from now, 3 years from now, so on and so forth, there might be more genes to test that we don't know about today. And that's why DNA banking can also be a helpful option to consider. What DNA banking is, it's just taking a DNA sample and storing it somewhere. And that allows us essentially to say, well, in the future, if me and, if I have ALS-FTD or my loved one has ALS-FTD, but I'm not going to be able to give a sample, well, at least my family members will already have a sample stored that they can draw on to do the testing, and that will help us learn and confirm whether any of these new genes that we've, discovered are explaining the family history. And finally, it's possible that we get an uncertain result. So again, genetic testing is just looking for differences in the genes that we look at, anything that looks different from what we normally see. But the reality is, we don't necessarily understand the implications of all of the differences we find. Everyone has genetic differences, but not all of them cause health problems. And so when an uncertain result comes back, that's essentially saying, hey, we don't know if this is our answer or not. We don't quite understand this specific genetic difference. Sometimes if the lab feels that we're close to understanding it, they might offer to test family members and say, hey, if we learn more about your family, we might be able to confidently say one way or another whether this is our answer. But a lot of times what happens with these uncertain results is we say, let's pause, let's wait and see if over time we learn more about the specific genetic difference or we understand it better. But this is useful information for you and your family to have. Keep track of this variant, okay? So I want to zero in on this C9orf72 gene because it really is a big player in the ALS-FTD world. And it also works a little differently than some other genes. So lots of these genes start to cause problems when there's one single letter in the genetic code that might be changed, or a piece of the genetic code that's missing. The C9 gene works a little differently. You can see all the letters written out on the bottom. These are what we would call repeats. The letters G, 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 C, C are repeated over and over and over, and that's true for everyone. Everyone's C9 genes have these repeats. The question is, how many repeats does somebody have? So there is a normal range, I would say 25 or less is about what we would call it, where if you have 25 or less repeats in this gene, I'm not worried. I don't think you're at risk for ALS or FTD. This is what I would call a normal result. There's kind of an intermediate range, 25 to 60 is probably what people would say, where some people with that number of repeats might be developing these conditions, but others aren't. We're not quite sure what to say about it. And then 60 or more repeats in one copy of the C9 gene is thought to be what we would call pathogenic or disease-causing. And what that would mean is you are at an increased risk for developing ALS or FTD or both. What I will say is that in the past, people have interpreted these extra repeats, 60 or more, not necessarily as increased risk, but as 100% guarantee that someone would develop ALS or FTD. The more we learn, the more time that goes on, the more we see that there are people with these extra repeats who aren't necessarily developing the disease. They might be more common than we thought. And so I'm hesitant to ever say someone has 100% chance or 100% full penetrance of developing the condition. But certainly it's fair to say if you have 60 or more repeats and one copy of your C9 gene, you're at increased risk for developing ALS or FTD or both. Those are going to be the most common conditions associated with this gene. But there have been people who have received other diagnoses and done genetic testing and found these extra repeats as well. So all that to say, the C9 gene often causes FTD or ALS. Those are going to be our #1 conditions. But things like Alzheimer's, Parkinson's, Lewy body Huntington's, there have been people that have received those diagnoses instead that are thought to be still linked to the C9 gene. Okay, so how does this run in families? What does this mean? Well, for almost every single genetic form of ALS-FTD, it's going to run in what we call an autosomal dominant fashion. And essentially what that means is that if someone has that condition or that genetic result that's positive, every single one of their biological children is going to have a 50-50 chance of having inherited that genetic difference, and therefore a 50-50 chance of having that genetic risk. Autosomal is just a fancy way to say it doesn't matter if you're a girl or a boy, all sexes can be affected. So anyone with that genetic difference will have that increased risk. And again, it's that 50-50 chance of inheriting it. So lastly, again, circling back to this important question, let's say that I have a positive result or an uncertain result. Well, what about my family members? What should I tell them? What should I be concerned about? And I would kind of summarize that in 2 questions that you should be asking. The first one is, do they even have this variant? Do they have the same result? Family members can do what we call targeted testing, which is essentially saying, let me do genetic testing for the specific variant that I know runs in my family to find out whether I even have it or not. If family members don't have the variant, I wouldn't necessarily expect them to be at increased risk for developing the condition. But if they do, and that's question number 2, well, does that mean that they're guaranteed to develop ALS or FTD or both? And again, circling back to what we talked about with the C9 gene, I would say I'm hesitant to say, yes, this is 100% or even a 90% risk or something like that. There's a lot of uncertainty around trying to quantify exactly how much risk is present with any one genetic difference. What I would say is, if you have a positive genetic test result and you don't have any symptoms, we definitely know you're at increased risk. How much can be hard to tell, but at least we know there is some risk there. And so again, just to end, here are some resources. The ALS-FTD study is a great study that's going on to be a part of. The FTD registry as well is a great place. And I suggest asking a lot of your providers about these things as well. And then End the Legacy also focuses a lot on research for genetic forms of ALS and FTD, and is working a lot trying to promote policy changes and things like that. So these are great things to look into and be a part of. But now Dr. Sullivan's going to come join me again, and we're just going to leave some space here at the end for any questions.
There we go. So I think we just have a few short minutes, but
Okay. Thank you. I was having trouble unmuting. My apologies. So Dr. Sullivan and Julia, thank you so much for that very informative discussion and all of the wisdom you've shared with us today. We have time for just a few questions. I have some from the audience here that I'd like to go over with you. The first question is, I have C9 and mild behavioral variant FTD that was diagnosed in 2020 following a 3-year journey. What are the odds that I too could develop ALS eventually?
okay, we're unmuted.
Sorry guys, we were having some trouble there. Yeah, no, so great question. And again, it's hard to give precise numbers on any of this. I would say it's still going to be the minority of people who go on to develop both. So it's not like we're saying if you have a diagnosis of ALS or FTD and we know it's due to something like C9, you should just be prepared to develop the other condition as well. So I think it's going to be the minority. Off the top of my head, I want to say maybe it's a 10 to 30% chance, is somewhere around there. But again, I hesitate anyone to take numbers to heart because numbers change with research and research is ongoing. So it's not guaranteed and it's the minority is probably what I would say most confidently.
Okay, that's really helpful. Thank you. There's a follow-up question to that from a different audience member saying, are there other genes, specifically the GRN gene, that could also lead to an FTD-ALS diagnosis, a dual diagnosis?
Yeah, good question. So the GRN gene is going to be mostly associated with FTD. There might be some movement difficulties that come up with it as well, but I'm a little less concerned about it being ALS. It might be other forms of movement difficulties. All of these genes are causing problems in the brain, and the brain helps us move and think. So, you know, we might find overlap with a lot of different genes, but for GRN specifically, I'm mostly worried about FTD. I'm not really worried about ALS.
Standing as well. Okay, I'm going to try to squeeze in one more question. Is there a way to tell whether somebody will develop either FTD or ALS if they have a positive genetic test result and they haven't developed any symptoms yet?
Yeah, so genetic testing, unfortunately, is limited in its capabilities of what it can tell us. It's not a crystal ball. And so right now, there's not really a way to tell. Let's say you have a C9 repeat expansion. I'm not able to tell you from that whether you'll develop FTD or ALS, nor am I able to tell you by looking at your family history. Honestly, it feels a little random right now, and we're working hard to understand why that's the case. But to answer the question, no. It tells you you're at risk for one of those conditions or both. It doesn't tell you which would come first, anything like that.
Exactly. That's my understanding as well. Okay, in a moment or two, we'll automatically be leaving this breakout session and we'll return to the main conference for the rest of today's sessions. If you have any additional questions, please email the info@theaftd.org with any questions, and we will try to respond to those once we get home from the conference. Okay, so thank you for joining us today for this very informative session. Thank you so much.
Thank you for having us. Thanks, everyone. Bye-bye.
Bye-bye.